Next week, TopMedTalk is live at Anesthesia 2019. Experts from around the world with the latest advances in anesthesia, pain and perioperative medicine help to shape the future of the specialty in the UK and beyond. Go to topmedtalk.com and check out the show notes to this podcast. Limited places remaining on Wednesday the 22nd of May to Anesthesia 2019. Go to www.topmedtalk.com.
Top Med Talk. Welcome to the latest in our series of Top Med Talks 2. In these podcasts, the Top Med Talk team is in conversation with global thought leaders in perioperative care. Top Med Talk. Hemodynamic monitoring and management. Now, recently, some of our most popular pieces have been the relief trial, i.e. the amount of fluid given perioperatively, and what an impact that's had on patient outcomes. We also, next most popular piece has been the Fedora trial, the use of advanced cardiac output monitoring to guide proactive hemodynamic management with manipulation of cardiac preload, afterload and contractility. So one, the amount of fluid, the other one, more detailed measures. Now, cardiac output monitoring's been with us for the whole of my career, and I'm getting pretty old now, looking over the horizon to retirement. And in readily used bedside formats, it's really been there since the 1990s. So the widespread use of the pulmonary artery catheter was followed by developments such as the esophageal Doppler monitor, pulse wave analysis from arterial lines, and more recently using minimally invasive technology. Now, in parallel, some would argue much more exciting developments has been the growth in the use and usability of echocardiography. So today I'm delighted to introduce special guest Dr. Davinder Ramsingh, who's Director of Research and Perioperative Ultrasound at Loma Linda University Medical Center, the Department of Anesthesiology, in Loma Linda, California. So Davinder, how are you this morning?
Very good, Monty. Thank you very much for the opportunity to talk.
Well, it's really great, very generous of you to give up your time. I know you're one of the emerging international experts in this field, and made some very significant contributions yourself, particularly with regards to education in this space. If I can just go over a couple of things. You did your residency at Loma Linda, which is where you are back at the moment, and you completed a cardiac anesthesiology fellowship at UCLA, and after that you joined the faculty at the University of California at Irvine, UCI, where you served as Director of Cardiac Anesthesiology. Have I done my homework well?
That's absolutely correct.
So I have to give you something to say now. So I think everyone now is pretty familiar with ultrasound. But I tell you, when I was a resident on the intensive care unit at Middlesex Hospital, I remember one of the attendings, consultants as we called them, wheeling up this machine, this massive machine, to wave on someone's belly. This must have been about 35 years ago, and generating these really weird fuzzy pictures that we couldn't make any sense of at all, where he was trying to look at whether the gallbladder was swollen, for example, without taking the patient down to X-ray. Mm-hmm. Then about 25 years ago, I was privileged to go to Duke University Medical Center and met Fiona Clements and Norbert de Bruyn, where I was one of the cardiothoracic attendings there. That was the early part of my life. And I was exposed for the first time to this new technology, as far as I was concerned, which was transesophageal echocardiography, TEE, as you all refer to it, and TOE, because we spell esophagus slightly differently, as I referred to it. And that was a really rapidly evolving field at the time. We had these very primitive monoplane probes. The omniplane probes were just emerging. Colour was just starting to come in. Where did you join that journey? Because you're significantly younger than me. When you got into your fellowship, where were we in in the OR use of transesophageal ultrasound?
When I was going to fellowship, this was in 2009-10, the availability of echocardiography, specifically transesophageal, had become very commonplace in the operating room in the cardiac suite. The concept of 3D echocardiography was becoming more and more of a true modality that we were wrapping our head around into its clinical applicability. That was the advancement of that time, the incorporation of this technology becoming more and more of a standard for cardiac surgery as a tool to use to evaluate patients through that cardiac surgery experience. And then the incorporation and development of 3D echocardiography. That's, the advancement of that technology, of this modality of high advanced cardiac imaging has really taken off to the point where now, again, the idea of real-time 3D echocardiography has really kind of been involved into that space. But ultrasound imaging itself has taken many other avenues as well.
Absolutely. We'll come back to that in a second, but just to be clear. I think if you're a cardiothoracic anesthesiologist in the world and you have started in, let's say, for example, the last 10 years, as you described, you'd regard it as being normal to do transesophageal echo, including those further exciting developments you've talked about, like 3D echo. So it's just part of every day at the office in that environment.
That's correct. It really has become a tool that we use, as you allude to in the first part of this talk, as just another monitoring tool that is now part of our everyday workflow.
So those people who aren't in this specialist field, who haven't seen 3D echocardiography, you should really encourage them to look at some images which you can get on a website. Go to YouTube, do a search. They're really stunning images, the ones I've seen. I'm not working in this world anymore, but I've been exposed to the images. They look amazing.
Yes, the advancement has taken off, going from something that was very cumbersome to something that truly you can apply in a real-time basis in a clinical setting.
Now, that has become very familiar in that world, and it's, I think the training and education is quite well regulated. There's certification associated with it. There are some extremely good structures. And then more recently, we've seen the very wide availability of transthoracic ultrasound. I mean, those probes can be used in different ways, being ubiquitously available in the worlds that we work in, the well-resourced world, partly driven by the use of ultrasound to guide central line placement and or to do nerve blocks. They're sort of everywhere now.
Absolutely. That availability of that technology has really just become explosive. The availability of portable ultrasound devices is a rapidly changing area. More and more, it's a regular tool that anesthesia suites and environments have multiple ultrasound devices to assist with, as you mentioned, regional anesthesia, vascular access, and more, it has become a standard to use those tools to be incorporated into those, anesthesia procedures. And very interesting to see how it doesn't necessarily have to stop there, right? And I think that's the really exciting part of all this, is that as ultrasound becomes more available, we are really exploring how we can incorporate it into, other avenues of acute care assessment.
So around the first time I met you, Davinder, I think you were at UC Irvine, and you'd been leading this innovative new teaching program for anesthesiologists to do this whole body point of care ultrasound, which I've learnt to call POCUS, which we hope isn't hocus pocus, but point of care ultrasound. Can you expand on that? It looks like a good thing to me.
Overall, the idea of point of care ultrasound, or POCUS, is taking these portable ultrasound technologies. It has allowed us to explore how we can potentially use these devices to help with our bedside assessment. And as you mentioned, in Irvine helped start and develop a curriculum of developing a new way of looking at how we can incorporate ultrasound to look at crude assessment of cardiac, of pulmonary, abdominal, with the idea, as the umbrella of point of care ultrasound is generally approached as the idea of helping acute care management. So you have a clinical question of cardiac function status, pulmonary function status, abdominal function status, and you now incorporate ultrasound to your bedside assessment, where traditionally, we've been using the stethoscope to help with our bedside physical exam. How we can use ultrasound to facilitate that evaluation process.
To repackage some of that, because I know some people listening will be thinking, whoa, hang on a second, you just suggested that we can replace the stethoscope here, which I've seen and I am a believer. So you've done your typical history and initial examination, and you've come to the conclusion that you think the principal problem here is probably in the heart. And now, rather than primarily listening, you're going to look. Correct.
This is just another tool to help in the bedside assessment. Stethoscope definitely still has its purposes. What we're trying to suggest is, in that situation where you have already identified perhaps the concern for cardiac pathology, how we can incorporate the tools available, i.e. ultrasound, to help further give more information. This has been evaluated in many different settings about if you take a board-certified cardiologist, a medical student, and compare their ability to diagnose a pathology, ultrasound versus stethoscope, time and time again it's been proven that the person with the ultrasound device, irrespective of their level of training, comes off better in their ability to appreciate the acute assessment of that pathology.
So I think many people now would have been very familiar with cardiac ultrasound, but now the expertise has developed such that lung imaging, as you were saying, and intra-abdominal imaging and other body compartment imaging has become mainstream. People are learning to interpret the ultrasound signals from, for example, the lungs.
Yes, again, going back to how now this technology has really just become so much more approachable, right? The ultrasound machines of today are no longer these big, large devices that you have to wheel from one corner of the hospital to the other. You know, they truly are laptop systems, portable systems that fit in your pocket, right? And so with that availability, it allows us to learn more how we can use these modalities. As you said, there is now much more rapid growing body of evidence of showing how we can use ultrasound to evaluate pulmonary function. Looking at the airway, for example, we can use ultrasound to evaluate appropriate location of the endotracheal tube, diagnosing vocal cord abnormalities, looking at the abdomen, specifically looking at the stomach to evaluate for gastric content. Really, you know, the list, as you mentioned, we took an approach of trying to develop a whole body assessment curriculum to evaluate how we can incorporate ultrasound for the common clinical perioperative questions that we have, how we can use ultrasound in the evaluation assessment of those various perioperative concerns.
So relating to my tee-up on this, because two of the popular articles we've been dealing with recently, which you know is one of my passions, I think it's a shared passion,
yes,
is about perioperative hemodynamic monitoring and management. And although I think the technologies are extremely good now and commonly used in the operating room, the operating theatre, it's not unusual for the patients to fall into a sort of grey zone when they get into the PACU or the immediate post-operative period where the monitoring's been stepped down, they've been extubated, and now it's much more difficult to evaluate their hemodynamics and people are often back to flying in the dark. It seems as though point-of-care ultrasound has a huge amount to offer there.
So you're absolutely right. You know, we've done several studies across different patient care settings, and you hit the nail on the head about identifying those sort of grey areas of where the care has de-escalated, but it's still in the purview of the perioperative team, and how ultrasound can help assess the acute evaluation of patients. Again, in that moment where you're at the bedside and you're left with the tools that you can reach, again, at the bedside, stethoscope, looking at baby and EKG tracing, those kind of modalities, maybe asking for a portable chest x-ray, how we could potentially use ultrasound in that setting to, again, sort of get more information to help evaluate us when we're in those settings.
So let's imagine the patient who has had major intra-abdominal surgery, who's gone to the PACU area now, things are going quite well, but they then have a hypotensive episode and they don't have an arterial line in and they've had a fluid bolus and the blood pressure hasn't come up. What would you look at, apart from your general history examination, what would you do with your probe?
I think several different things. One, we would take a quick look at cardiac function to evaluate every time, obviously, if the patient has an issue perhaps of being hypotensive, always trying to evaluate this is the basics, right? Is it a volume status issue? Is it a pump issue? Or an SVR issue? And ultrasound can help us delineate that very quickly. We can take a quick look at cardiac function. We can look at the filling of the heart. Again, all from a fairly quick and rapid point-of-care assessment. We can do evaluation of their carotid artery flow and look at the variation in the pulsatility of that flow and determine fluid responsiveness, or at least determine the increase in that flow pattern with the passive leg raise, very similar to looking at a increase in stroke volume from non-invasive hemodynamic monitoring as a same technique to see for somebody who could be fluid responsive. And those are just some modalities. We can scan their abdomen to make sure that there's not a rapid free fluid collection, which is the FAST exam, to help delineate potential mechanisms of hypotension. You know, really the list is quite expansive of what we can do with ultrasound to help tease out mechanisms and kind of, again, identify appropriate levels of care much more rapidly. And that's really what we're seeing. We're seeing how that differential gets more narrowed and focused when you incorporate ultrasound into our bedside assessment.
And increasingly, as you've referred to, I see people, colleagues, I see in trade exhibitions, etc., that the ultrasound devices have gone down to the sort of size of a big iPhone. There are other phones available. You know, it's a handheld device that you can pull out of your scrubs and make that assessment rapidly, akin to the stethoscope availability.
Yes, and that's really what allowed us to kind of help focus this into an idea of how we can use this tool as a bedside assessment monitor. And I think that's the key emphasis here. We're not talking about formal medical ultrasound imaging. This is point-of-care ultrasound is its own modality that potentially should be incorporated, developed. You know, that's an area that I'm very passionate about, how to develop the education and certification and explore that avenue so that we can learn how to better incorporate this into our medical education process here in the States. Because, again, the technology has become so portable and available, but the education and the process of developing how to actually incorporate that, I think we're a little bit lagging on that area.
Okay, so to that very point, I'm an old dog, but I like to learn new tricks. If I want to get into this, apart from talking to clever chaps like you, what do I go on a course? Do I go to a teaser course? Do I go online and find some educational tool? What's my route of entry?
That's a great question. There's workshops that are going around more and more internationally and in the U.S. here. For example, we lead a workshop on POCUS education. I have our curriculum. One of the things transitioning to Loma Linda, we were able to get a departmentally sponsored effort to transition our entire curriculum to an online platform that is completely open source, copyright free. It's open to anybody to access on the web so that they can, again, we don't, there's no subscription or cost associated. It's really meant to be an avenue and portal for open access education on the topic. And I think more and more there's other centers that are exploring that and developing it. But we're at that still exposure level stage where we're really trying to develop this into formalized, structured curriculums. And I think as more and more centers, collaborate on this topic, we can get to the next level. Similar to, as you mentioned, the history of transesophageal echocardiography, right? Going from the exploring the new modality to making it into a certified process. One area that I'm very passionate about is how to incorporate this topic into core competency training for our residents. I hope that happens in a relatively short timeline. But, we're doing our part by trying to get that information out there on an open source online platform.
So I've just pulled up the website there, which looks great. That's pocuseducation.com. We'll put a link to that in the piece that we put up afterwards. I'm looking down here at a video to watch Z-Dog MD's segment on POCUS Below. What's a Z-Dog and where do you find one of those? This sounds like a California thing to me.
He's Stanford trained, and he's a very interesting gentleman who has really tried to incorporate the idea of how to break down sort of the silos of various areas of medical care in the U.S., and he has kind of developed many community videos and has a huge sort of following on not only just medical comedy, but also insightful opportunities of education on new kind of upcoming technologies. And again, very appreciative of him to have the opportunity to talk about the topic as just an awareness piece about helping to get the word out there. And, he very much is on the, here in the U.S. as a following to kind of talk about changes in healthcare. He embraced the topic as something on that nature about how perhaps point-of-care ultrasound is something that could help change healthcare by improving our bedside assessment. The stethoscope is almost 200 years old. Any piece of technology in any industry, and you try to see it having a lifespan of 200 years, that's very impressive. And so perhaps there's room for us to add something else in our bedside assessment besides the stethoscope. And with that, he was very supportive of trying to help get the word out there.
Brilliant. And I've now opened the agenda for it. Now, we've got to be clear there are numerous courses available around the world, but you're the one on the phone. Yes. So I've opened up here the upcoming Perioperative and Acute Care Ultrasound Workshop, over 6 hours of hands-on training, and the next one, I think, is coming up in September. Is that right? 22 and 23?
That's correct.
At the Hyatt,
California.
Yeah, the Hyatt Regency, Huntington Beach, California. I'm looking at the picture there. That's a terrible place to hang out. I can see that's awful. And that includes didactic training, 17 hours of credits, and what looks like a stellar faculty there that's going to give you a chance. You say about 6 hours of hands-on.
That's correct. We really try to focus on giving brief didactic lectures, focused lectures, and then spending the majority of time of getting hands-on image acquisition. And this correlates well with our educational site, foresightultrasound.com, to have the material as well for education. So we try to use both sites as avenues to explore the topic and try to get our part to help educate.
Fantastic. Well, I'm going to have to see if I can get around to doing that. Davinder, wonderful to talk to you. Anything else you'd like to add at this stage? Congratulations on all this fantastic work you've done. I mean, the medical students will just learn this all by default before too long. But somehow we've got to get us older folks given an opportunity to bring this to our patients. Anything else to add at this stage?
No, again, thanks for the opportunity to have this talk. It's always a pleasure speaking with you. And I think, again, just the awareness on the idea of that this technology and modality is out there. And I think it's only going to become more and more penetration into our space in the perioperative setting. And so I think it behooves us to figure out exactly how we can incorporate that into our clinical care.
So that's, thank you very much. That's Dr. Davinder Ramsingh from Loma University talking to us about point-of-care ultrasound and other applications of ultrasound. So please don't hesitate to look up www.pocuseducation.com.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.